So students, the topic for today is fever with thrombocytopenia, and the organizers are Dr. Akhilesh Tandekar, Dr. Gunadhar Pari, and Dr. Asif Iqbal. The case presenter that we have here is Dr. RUPAN BHADURY, who is a DRNB critical care resident. The moderator we have here is Dr. TANMAY BANERJEE. He is a senior consultant and director at Medical Super Speciality Hospital, Kolkata. We have the examiners, Dr. MOHIT KHARBANDA. He is a senior director of critical care at Desun Hospital, Kolkata. We also have Dr. SASWATI Sinha ma'am. She is a senior consultant at critical care at Manipal Hospital, Dhakuria, Kolkata. Rupan sir, you may take over.
We have an interesting case with fever and thrombocytopenia in a young lady. So we'll discuss as we go along. Rupan, you can start now.
A very good evening to all the respected faculty and my fellow colleagues who are present here. And today the topic is fever with thrombocytopenia. Myself, Dr. RUPAN BHADURY. I am a DRNB resident at Medical Super Speciality Hospital, and my moderator is TANMAY sir.
Okay, sir. So you can start. We have Saswati ma'am here, and also we have Mohit sir.
Patient gets admitted from outside hospital with history of altered mental status with progressive drowsiness, diffuse joint pain, and sudden onset menorrhagia for 2 days. And the outside report shows bicytopenia with significant anemia, critical thrombocytopenia, and high LDH around 1000, 1200. And CT brain was also done outside. Now coming to the history, she's a 17-year-old unmarried female from Jharkhand with no known comorbidities, presented on 22, 1 and 25 with low-grade fever, menorrhagia, altered mental status, and diffuse joint pain for 7 days, for which she was taken to a local hospital where they suggested ultrasound abdomen. She drank a lot of water to fill her bladder, followed by which she started vomiting. After the few bouts of vomiting, she became confused and restless. She was taken to the local hospital where she was admitted, catheterized, and as she was passing high-colored urine, and 2 units of PRBC was given to correct anemia because hemoglobin was 4.9. It was corrected to become 7.5, and she was then referred to our hospital for further management. Now, on examination, the patient was drowsy but arousable. Her GCS was E2V4M5. There was pallor present, icterus edema was absent, clubbing was absent. Her respiratory rate was almost normal. The pulse was a little bit tachycardic, hemodynamically stable. The saturation was 86% at room air, but with 4 liters of oxygen via nasal cannula, it rose to 100%, almost around normal. Temperature was 99.9. Urine output was adequate here, and there was minimal ABG on the minimal hypoxia on the ABG. And on examination, the skin, she showed malar rush sparing the nasolabial fold, ecchymotic patches in both the upper limbs, and erythematous rash was present in the left palm. Now coming to the examination, GCS E3 before M6, plantar was bilateral flexure, neck rigidity was absent, pupil was bilaterally reacting to light, the tone was almost normal in 4 limbs, the Cardiac sign was negative. There was fine respiratory creps in the right lower lung zone, and CVS was normal except for tachycardia and chest. There was bilateral creps was present in the initial examination done showed a hemoglobin of 7.
Rupan, please stop. Rupan, please stop.
Yes, sir.
Yeah.
Hello.
Yeah. Tell me, what is your thought process at this time?
At this time, the patient
you have
coming
received the patient with the above history, and you have done the initial examinations.
Yes, sir. So, with the clinical examination, if the patient is coming with bicytopenia with low hemoglobin and thrombocytopenia with platelet count around 8 to 9,000, we have to rule out all the causes of thrombocytopenia initially. So first, since the patient had crepes on the left side, we had we thought about pneumonia with severe sepsis. Although the ABG was not showing much derangement and hemodynamic patient was stable, other causes of thrombocytopenia has to be ruled out. Like so, all the causes of thrombocytopenia, including platelet production, there's fault with the platelet production or increased platelet sequestration, has to be ruled out there. And hemoglobin 7 and 7 platelet count was 8,000. So bicytopenia, we could suspect sepsis here.
So that is after investigations. You do not know the investigations yet.
Yes,
don't you?
yes.
Okay, sir.
I think, Mohit, at this point of time, I think three differentials definitely you need to consider. One is there any HUS TTP, number one, or sort of microangiopathic hemolytic anemias? Second is either a sepsis with DIC. Number three would be an autoimmune disease with ITP. So obviously, this all depend on a clinical presentation. The patient has CNS involvement and also some renal involvement as well. And definitely platelets are like low, and the HB is also low, and the LDH, as Rupan said, was high. Now the other thing is that
Because that is all after investigation.
yes,
And
yes.
I think
Clinically,
then you only
yeah.
have the history and you have done the examination. So
Yes,
and
clinically,
we have to have a thought process. We have to have a DD based on the
yes.
history and examination, that which way I am going to proceed and how am I going to investigate this patient further.
Yes.
So
Yes, sir. So,
so that plan has to be made on the basis of history and examination. Now, in this case, of course, while we are presenting this, you know all the details. But when we are doing it for a teaching purpose, then we have to be able to develop a thought process.
Yes, just from history and examination.
yes, from history and examination, as the patient was having pallor and there was hematuria present, so first we have to also rule out glomerulonephritis or any associated renal diseases the patient might be having, or microangiopathic hemolytic anemia. Since the patient was restless also, so neurological manifestations was present. So kind of autoimmune diseases has to be ruled out, like SLE, and with the purpuric patch present and sparing the nasolabial fold.
I think
SLE is
as
also
per the history and the initial examination, my first thought would not be going towards autoimmune diseases per se. Microangiopathic hemolytic anemia, yes, that is a definite possibility. The patient had petechial hemorrhages and ecchymosis. The patient had history of fever. The patient has altered sensorium. So definitely microangiopathic hemolytic anemia, yes, it would be definitely a possibility. I would think of at this moment, first thing I would want to rule out, but we always need to remember that common things are more common.
Yes, sir.
So in our type of scenario, so tropical fevers are the first thing that need to come to our mind. So we at this stage, can we say that this patient has dengue or this patient doesn't have malaria? So rather than going first thinking of autoimmune diseases in our scenario, my first thought would be ruling out tropical fever. Second would be ruling out sepsis. Third would be, of course, microangiopathic hemolytic anemia, that or TTP, to be more specific, would be what my thought process would be at this time. Malar rash sparing the nasolabial fold. Now, this malar rash is generally would be maybe present on history, but you wouldn't mostly get a malar rash in the ICU patient. It's unlikely that you would get a malar rash in an ICU patient. That is generally its photosensitivity, which is generally more evident on exposure to sun. So the patient who's been in the hospitals for last 7 days is unlikely to have a malar rash per se.
This was present on admission. Subsequently, this actually disappeared, so we couldn't get a photo to show you. But on the first day of examination, it was present. You're right.
Sir, slides are actually not moving. We are not able to see the slides.
Right.
So we're moving to the next slide.
Yes. You're able to see the slides or not?
Never. No slides seen at
The
all.
slides are not moving, Tanmay.
From the beginning, nothing is shown.
Please try
Yeah,
to
we are just
check.
able to see the title slide.
Okay. That's all. This one.
Screen.
Now, let's see. Is it moving?
Yes, now
Now
it's
it's
moving.
perfect.
Yes, yes,
Okay.
it's moving.
Okay, all right.
So
1 minute. Just we just slowly
Just
show the slides again because they have not been able to see. So this was the. Can you see the hands now? The picture.
Yes.
Yes, sir.
Okay. Shall we now move on to the investigations?
Sure.
Okay.
Yeah, please go ahead.
So the initial investigations done here was CBC and which showed hemoglobin 7 and platelet count was 8,000. CRP was high, so it was around 89. Sodium potassium normal. Urea 78. Creatinine was 2. And INR was little bit deranged. It was 1.45, but still less than 1.5. Bilirubin was 2.2. Unconjugated 1.3. And SGOT was mildly raised. The rest of the parameter was almost normal. The urine analysis was done since there was hematuria. There was blood 3 plus, protein 2 plus, and it was loaded with RBC. Rest there was no evident pus cell present. So the radiological investigations that was done here, CT that was done, which showed hypointensity in the right frontotemporal area, indicating potential cerebral edema. Chest X-ray revealed mild haziness at the right lower lung zone. Echo did not reveal any vegetations, and the ejection fraction was also normal. USG abdomen done revealed bilateral moderate to gross increase in renal cortical echo texture with loss of corticomedullary differentiation, and there was minimum bilateral pleural effusion and mild ascites. And arterial and venous Doppler was also done eventually, which showed normal study. So the DD that we suspected after the patient was shifted to the ICU and with the investigation was SLE, ITP with secondary AIHA, catastrophic antiphospholipid syndrome, sepsis-induced DIC, TTP, drug-induced TTP, infection-associated TMA, scleroderma renal crisis, and CNS infections or acute encephalitis syndrome.
Mohit and Sashwati, any comments here? Like in terms of how RUPAN has put the DDs, in terms of which one you will keep at the top?
I would feel, Rupan, how would you categorize? You have put a sequence
Yes, ma'am.
depending upon the history, physical examination, and the investigations which you have. How would
What
you,
madam is,
put it in a, how would your approach be? What
what
would
madam is
you think
asking
this
is
would,
that what is your
which one of
thinking
this should
behind
be on top?
this? Yes, this so putting actually on top, like the sequences of the differentials you have put in here.
Yes,
Madam wants to know your thoughts. Why you have done
Why
1,
is
2, 3
SLE on
that
top?
order?
And why, for me, I
because
think the sequence would be different. So I want your approach. How would you?
initially I thought, yes, ma'am. Since the patient was shifted from the emergency to the ICU and certain investigations were done, so SLE came to my mind initially because there was malarious present and also the renal function was deranged here in this case, and also there was the creatinine was high. So the first thing that came to my mind was SLE, though it is quite rare here. And second thing, we actually could not rule out CAPS here because eventually the ferritin level was also on the higher side in the patient. And sepsis-induced DIC is always a common factor in such cases because there was pneumonia was present, haziness was there on the right side. So sepsis-induced DIC was also the third thing that came to my mind. And drug-induced TTP, the patient did not give any history of significant drug that might cause an immunological or non-immunological destruction of platelets. So, and
Rupan,
yes, ma'am.
see, you had mentioned the history was very short, right? This patient is a 17-year-old girl, and she had a reasonably short history. Even her joint pain history was short.
Yes,
Probably
ma'am.
the thrombocytopenia history also we probably don't have an old thing that she's probably had another episode of thrombocytopenia in the past that we will think of ITP. Also, with this sepsis induced DIC, yes, that could be very much possible. the altered sensorium, she came in with fever. We were initially, I think Dr. Kharbanda also spoke to you about the tropical fever. So, with a short history with fever, altered sensorium, thrombocytopenia, you should always think of tropical fevers first. Also, you mentioned that this patient, in order to have an ultrasound, she had multiple episodes of, she drank a lot of water and then went into altered sensorium. And then you said crepitations on the right base or left base. So wouldn't you think about aspiration pneumonia in this situation, which can the altered sensorium could be due to could be due to a metabolic disorder. So those things will need to be put first, and then once you get the investigations done, so this will be on the basis of your history, and then once you have your investigations, then you can categorize things further. So SLE and catastrophic APLA, I think in all our clinical practice over a period of, those are a little uncommon diagnosis. So you should put the ones which are more common first. And I would feel that sepsis, metabolic encephalopathy, of course, TTP would be one of the differentials, but I think SLE and ITP and catastrophic APLA, these would need to go much down in your sequence of differentials. Tanmay, what do you think?
I think you're right. Of course, we get biased when we present a case after seeing all the investigations.
That's
So
true, because we know all of it. So, but
that
you
is
know,
what
in
it
your
is. That is what it
exam,
is. So
that approach.
in exam, Rupan, obviously, you have to go first by history and examination, then the investigations would come into a discussion. So as per the history and examination, as Dr. Shashwati said rightly, that the sequence probably should be a bit altered,
A
changed.
bit, yeah, you need to modify the
Yes.
sequence a little bit. So, what did you do going ahead?
So, Rupan, how do you differentiate acute arthritis and chronic arthritis? When we talk of rheumatoid disorders, we generally look for chronic arthritis. So, what is chronic arthritis?
So we have to go for tests like ESR, CRP, and clinically there will be tenderness present, and the stiffness, the morning stiffness will be present in case of acute, and history of fever has to be there.
How will that differentiate between acute and chronic? How do you differentiate whether it is a reactive arthritis versus a rheumatoid arthritis or arthritis associated with SLE? How would you differentiate?
First thing, Rupan, is the duration you have to mention, definitely. How long the arthritis has been present. Number two is that sign of, that inflammation, acute inflammation, like redness, tenderness, and swelling. And number three is there a deformity? So deformity will come with chronic arthritis. So those kind of things, whether, first is the history, then the examination, then you talk about ESR, CRP, those things will come later on, because that can be raised in both acute and chronic arthritis as well. So, go clinical. First is the history, the duration of arthritis, how the onset of arthritis was, how long has it present. Then on examination, is that tender joint, which is swollen, acutely red, hot? Is it, how many joints are involved and all those? And is there a deformity to say that it's evidence of chronic arthritis? So that you have to say, definitely. That will be the answer from you. So.
Right.
Yeah. So, can you see the slides being changed now? Okay. All right. Go on.
So after the investigations were done and the patient was shifted in the ICU with oxygen support, she was initially given conservative management with piperacillin, tazobactam, and doxycycline. 6-unit RDP was transfused in view of low platelet count. DVT prophylaxis was given in the form of DVT pump, and pan-CS, including tropical fever panel, peripheral blood smear procal was sent. And IV fluid was started at the rate of 60 ml per hour, and bedside echo was done. So since the platelet was low and we suspected certain cause of thrombocytopenia, so pulse methylprednisolone was initiated in the patient, 1000 mg for 3 consecutive days, and it was advised. MRI brain was done after shifting the patient to the ICU, although the patient, it could not be completed because the patient was having severe altered sensorium, and in spite of giving sedation, the patient was not tolerating the MRI suit, so had to come back.
I'll stop you there. Pulse methylprednisolone was initiated after seeing some further reports.
Yes, sir.
So, those you have to show, because otherwise, with these findings and investigation only, you would not give till you have shown the other reports.
Yes, sir. So the blood CS, urine CS showed no growth. The procal was 0.39, and the thyroid TSH report was 0.6. Ferritin was very high. Serum iron was normal. Saturation was low, 16.2. Vitamin B12 was high, and the direct Coombs test was done, which was positive. LDH was also done, which was 1300. The retic count, the corrected retic count was 3.4, and fibrinogen done, which was on the lower side, was 148.
And tropical fever panel was negative.
And the tropical fever panel was negative.
Yes. Okay, so go.
And
Okay,
peripheral.
So what if I say this is macrophage syndrome, but mass?
So in mass, it has to be pancytopenia with increased ferritin, and also LDH level has to be on the higher side, and we have to confirm by a severe fever. It was not responding to antibiotics. So the mass did not actually come into our mind that time.
Now, what are the criteria for mass?
So for mass, the LDH, ferritin.
What is the LDH in your patient?
So in our case, LDH was
How
1200.
much should the LDH be? What are the criteria? Can you tell me serially?
6000. So LDH has to be more than 6000. Triglyceride has to be high. I think it's
LDH
500.
has to be more than 6000
LDH
for mass.
So it's 600. It has to be more than.
We never see 6,000. Rarely see we. So
LDH has to be more than 600. There has to be pancytopenia. Ferritin has to be high. Triglyceride level, and there's 5 and 6 criteria in there, and presence
there is a
of clinical
scoring system, isn't it? So do you want to talk about the scoring system? So like organomegaly, LDH, ferritin, triglyceride, as well as fibrinogen, those kind of all those things are there.
Right. So I'll just
Emu.
I think one is Tanmay, macrophage activation is pretty common. It is not uncommon in our scenario. It's a quite common diagnosis that is made. Am I audible?
Definitely. I mean, you are absolutely right, Mohita, when you were talking about macrophage activation syndrome here. That's a possibility, definitely. But
So
I mean,
we definitely need to keep that into consideration. We definitely need to
did consider that. We did consider that. But then picture was going more in favor of hemolytic anemia with thrombocytopenia kind of his picture, with the retic count being high, DCT positive. And also the other factor was that, peripheral smear, though the report says...
But I would like the student to be able to tell me how to differentiate. Basically, that is the point.
Of course.
That is the point I'm trying to...
You should read
the student should be able to tell me how to differentiate between
yes,
these
there is a scoring, and
H score has to be done.
Yes.
H score has to be done. So the various criteria can be fever, splenomegaly, bicytopenia. It's not pancytopenia.
Bicytopenia, sir.
Bicytopenia. Yeah, bicytopenia. Then hypofibrinogen in low fibrinogen levels you get. So generally the ESR will be also low. The triglyceride levels would generally be high. and LDH would generally be high. The ferritin levels would be high. So you have high ferritin levels here, although not extremely high that may be present in mass. You have high ferritin levels, and you have bicytopenia, I think. And
Yes,
have
but that is
bicytopenia.
possibility at this point of
You
time.
have
We should.
high LDH.
Yes.
You have high LDH and
Yeah, I mean, LDH, triglyceride, fibrinogen, retains, liver enzymes, all those things, organomegaly, fever, all those kind of things are there.
we
anyway,
have not checked for fibrinogen. Fibrinogen is 148, so it's sort of on the lower side, I would say. So there are certain criteria that would go in favor of mass. So yeah, that has to be sort of ruled out. Yeah, please go ahead.
Yes, sir. Followed by that, anti-nuclear antibody and titer was also done, which showed the dsDNA was positive, and the antibody profile showed histone antibody positive. And then the further management, pipzo was replaced by ceftriaxone, and HD access was done after transfusing 4-unit RDB transfusion. Plasma
So,
medicine
Rupan,
was
can you tell me the diagnostic criteria for SLE?
SLE is clinically the patient need to have the clinical features. There has to be malar rush has to be present in butterfly like pattern. There could be systemic involvement like serositis or fever has to be present, and the patient may have a history of certain drugs, and ANA profile, it has to be positive, and
it can't be half. It has to be positive. That is not how you do it, isn't it? There are various possibilities that can be there. It doesn't have to be positive. It can be positive. These things can be positive, and based on that, there is a scoring system by which you can score that.
Yes. So there's a diagnostic criteria.
Yeah.
Anyway, any negative glucose is there, but can happen.
Once you have a case which you already know you are going to present as a diagnosis of SLE, then I think you're supposed to know all that, isn't it?
Yes.
You're going to say the diagnosis is SLE, and you don't know the diagnostic criteria. That's not okay for a student, actually.
Yeah, Euler criteria and all that. I think we should have shown in the discussion. But anyway, I mean, it's a long case actually, in the sense a lot of things happened with this patient. So trying to keep it short. Trying to keep it short. But anyway, I think those things.
Tanmay, what
you are absolutely right. I think for a student, we should try to approach.
I'm just telling about how the students have to prepare.
Yes, exactly. I mean, you're absolutely right, Mohit. I should approach in a systematic manner. Not to jump into
the students have to be prepared. What you are presenting as a case, it's a very interesting case that I totally agree. A lot of things to learn from this case. But on the other hand, the students who are presenting also have to prepare accordingly.
I should read up Euler criteria for SLE.
So why pipzo was replaced by ceftriaxone?
No, I think I actually, to be fair, I didn't get time to see the slides. I would like to modify a few things. Like the antibody was downgraded because there was sort of, in a sense, we thought there was no active infection. It is all autoimmune kind of thing. But just to cover up in case of there is any sort of, pneumonia, I think ceftriaxone was good enough. That was thought. But sequence of the things.
Yeah, that could be also a possibility. Or many times, actually, the nephrologists do it. The nephrologists, sometimes they feel that pipzo can cause interstitial nephritis. So they many times stop pipzo and ask to shift to other things.
Yes.
So this patient already been having renal involvement.
Yes. And this slide, I would just like to actually just to tell the sequence in this slide is not right, Rupan. I tell you, so the HD access was done, but the patient received rituximab first, thinking about whatever diagnosis we thought about at that time in discussion, hematologists and rheumatologists. So basically, it was thought about SLE with thrombocytopenia. But then what happened is that rituximab was given, but after 2 to 3 days, plasmapheresis was given. That was for a different reason. So your sequence is not right here. So the fourth thing should come first. Rituximab was given
This
first.
was done first, then plasmapheresis was advised.
Advice. Plasmapheresis happened much later. So
Yeah, but it was advised initially by
no, advised by it was considered.
considered, yes, sir.
So they considered which one will be better and what are the possibilities. So we discussed about that. But ultimately, consensus was that to give rituximab and see. But then plasmapheresis was started after 2 to 3 days. You have to give at least gap of 2 days after giving rituximab to start plasmapheresis. Otherwise, rituximab will be washed out. You should bind to the receptors. So, you cannot say in this sequence. So, rituximab was given, and then something happened that you have to show everyone. Then I should talk about plasmapheresis. Okay.
Yes, sir. So initially, rituximab was given 1 gram, and the next dose was advised after 2 weeks, and then every 6 monthly. Followed by which nephrology advice was given, and sorry.
No. So basically, this is the next slide. Can you see the change in the slide?
Yes, it is visible.
Yes.
So on the 6th day of the hospital stay, she started complaining of abdominal pain. Amylase and lipase was done, which was very high. And then USG whole abdomen was also advised. The patient was conservatively managed for pain, and the reticulocyte count was also advised. The oral steroids was continued, that is methylprednisolone. Pulse dose was given, and then followed by which oral steroids were continued to the patient. And rheumatology review was done. And now the complement level was sent, which showed C3 count was on 50, C4 was less, and P-ANCA was positive, and C-ANCA was negative. And phospholipid antibody IgG was positive, phospholipid antibody IgM was negative, and the patient also had a positive anti-cardiolipin antibody. So gastroreferral done. So they advised MRCP, which revealed thickened and edematous gallbladder, prominent bilobar IHBS, diffuse dilatation of the common hepatic duct, mildly bulky pancreas with mildly dilated MPT, and was suspected to be mild acute interstitial pancreatitis. There was mild ascites and minimal bilateral pleural effusion. And she was also diagnosed with acute interstitial pancreatitis. So from there, ceftriaxone was escalated to meropenem and teicoplanin. On the 9th day of hospital, she developed melena, followed by which her hemoglobin level dropped. Upper GI endoscopy was done that revealed duodenal ulcer with diffuse oozing. Biopsy was taken and endotherapy was applied. So biopsy report, which we awaited, and it showed chronic active duodenitis and vasculitis. So
You don't have the video?
no, sir.
Okay, the video was deleted. So if the video could not be played, anyway, it's a video, you can see the pictures. The video is typical of vasculitis, and the pictures you can make out from the pictures anyway. So diffuse involvement, and you can see those vasculitic, evidence of vasculitis in the pictures as well. So at this point of time, this was day 3 of after giving rituximab. At this point of time, we thought the patient developed pancreatitis after rituximab and developed this vasculitis with GI bleed. So patient was going downhill, and we were obviously worried that rituximab probably was not enough, and we had to consider plasmapheresis at this point of time. So, and then it was started. So as not a sequence was not right, Rupan, earlier.
So the patient was also having intermittent fever spikes for which blood culture was sent, and it revealed growth of Enterococcus faecium, which was sensitive to teicoplanin. The MIC was less than 2 and it was sensitive to teicoplanin, so meropenem and teico was continued in the patient. And due to high clinical suspicion, the peripheral blood was also repeated. And asked the pathologist to look for schistocytes. There was significant number of schistocytes present, more than around 5%. So, the platelet was significantly reduced also, although the WBC showed no abnormal cells. So the thing that we suspected there was TTP, and plasmic score was done for the patient. The platelet count, which was almost around 8 to 10,000. So it carried a score of 1. There was hemolysis was present with increased reticulocyte count, and also indirect bilirubin was also high. There was no history of active cancer. There was no history of solid organ or stem cell transplantation. Then MCV was also less than 9, and INR was also less than 1.5, and creatinine was less than 2. So we have a high risk for plasmic score for TTP. So 7 is considered to be a high risk. So we considered plasmapheresis here, and
So at this point, you can justify the results, isn't it? So that is what you have to. The sequence of presentation should have been a bit different. But anyway, I apologize because I think I was involved with the case from the beginning till the end. But obviously, residents they, as they do duties on different days of the week, they may not have the like being involved day to day, which is slightly a problem. But anyway, this I think now we have got the story right for everyone. And Rupan, you can proceed.
yes, sir. So after that, ADAMTase 13 was down, decreased. The level was done. It showed a decreased activity of less than 5%. So we came to the diagnosis of systemic lupus erythematosus with secondary vasculitis, acute interstitial pancreatitis, and thrombotic thrombocytopenic purpura. And the possibility of catastrophic antiphospholipid syndrome also could not be ruled out. Although there was no evidence of thrombosis was found, but there was ferritin level was high. And so in our patient, increased number of cystocytes in peripheral smear, low platelet count, and in presence of autoantibodies related to SLE. And the response to plasmapheresis was also seen, and MRC findings got us to the diagnosis of SLE with TTP. So management, grossly, we did pulse dose methylpred for 2 days. But since the cytopenia was there and clinical condition did not improve after that, she was given 1 dose of rituximab on 25th January. After discussion with the nephrology, hematology, and rheumatology team. And then it was decided that we start with plasmapheresis after 2 days of giving rituximab. Maintenance dose of methylpred was continued, and mycophenol mofetil and hydroxychloroquine was also subsequently added. After 5 cycles of plasmapheresis, her platelet count remained within the normal range for 2 consecutive days, and then her clinical condition stabilized. During the hospital stay, she received a total of 5 cycles of plasmapheresis, 1 dose of rituximab, and 54 units of FFP, 6 unit PRBC, and 20 unit RDP. Now the patient was planned for kidney biopsy once she was stabilized, but biopsy could not be done due to financial constraints. She was discharged in hemodynamically stable state after 16 days of hospital stay, and on follow-up after 2 weeks, she has shown remarkable improvement in her symptoms and quality of life. Now,
yes, the patient is still doing very well. We had a telephonic query just day before yesterday, because she is from Jharkhand. She's not coming regularly to us for follow-up, but she's doing well and completely sort of symptom-free at the moment of time. Yeah, discussion go on, Rupan.
so TTP is an uncommon disorder characterized by classical pentad of microangiopathic hemolytic anemia, thrombocytopenia, renal dysfunction, fever, and neurological abnormalities. It is characterized by deficiency in ADAMTase 13, which is a metalloproteinase responsible for cleaving the 1 billion factor. This deficiency causes addition of 1 billion factor multimer and lead to platelet clumping and microthrombi in the microvasculature. So plasmapheresis is the mainstay of treatment, which actually kills the WBF multimers along with the enzymes that kill the ADAMTS13 and replace after giving replacement with FFP, we get an adequate number of ADAMTS13. So TTP and SLE really present simultaneously and generally constitute a diagnostic dilemma because of overlapping features. And recognition of TTP in the setting of SL is very important because the combination of both the condition carries worse prognosis rather than SLE alone. So early and aggressive treatment with plasmapheresis and immunosuppressive therapy, it requires multidisciplinary approach and is life-saving. After the acute phase, long-term adherence to medications like mycophenolate, mofetil, and hydroxychloroquine, these are also important, and regular follow-up is the need.
So to summarize, I think first of all, my apologies because I didn't get time. Today I was away during the daytime, so couldn't get time to check the slides with Rupan. But to summarize, Rupan, you should think, presenting in a systematic way where you discuss after history and examination, then you go to investigation and then discuss it again. And then, so don't be biased when you're presenting because this case probably you knew the investigations already, but don't get biased. So to summarize, I think initially the thought was tropical fever, yes, then SLE shifted to SLE, then actually SLE TTP. And obviously the patient was deteriorating and plasmapheresis saved her life. Rituximab was given thinking that SLE with thrombocytopenia and organ involvement. But then when we got certain it is TTP with vasculitis and everything together, which is a rare combination. I mean, we haven't, personally, I haven't seen many cases like this. So I think we had to go for plasmapheresis. Initially, there was bit of reluctance from the family to go for plasmapheresis, but after a lot of counseling, we managed to convince them. And I think that saved her life. So, yeah, comments from Shashwati, Mohit and others, please.
Rupan, what else? How, if you look at a patient with fever with thrombocytopenia, would you ask what would you ask your laboratory hematology laboratory to look at? Does that help you differentiate in a fever with thrombocytopenia?
Yes, ma'am. First is the routine blood test that is very important in this case, like CBC, including the peripheral blood culture to look for peripheral blood slides to look for schistocytes or presence of any helmet cells or any abnormal cells or lymphocytes or platelet size, that is megakaryocytes could be present, or to rule out any causes of malignancy also, because it may also present with thrombocytopenia. And next, the systemic functions has to be done like LFT, renal function tests, and the basic tests like chest X-ray, CT scan of brain. So with the pathologist, we have to be aware of the all the cells like which increases like reticulocyte count, helmet cells, smart cells. Might look for smart cells, and also presence of any abnormal platelets or platelet clumping could be present. So with thrombocytopenia, and if fever is also present, so we have to also go for the routine blood culture and pan culture, including CBC and total leukocyte count, CBC, CRP and procal to rule out sepsis, fibrinogen level to rule out DIC.
Okay. Yeah, so like Tanmay also said that henceforth, I know it was a wonderful case which you presented and really great management by the team. But when you present the case, henceforth, that's my suggestion, that actually you should go step by step, otherwise the whole approach to the case gets a bit diluted. So you should have a list of differentials after your history and physical examination. Then you put in your first set of investigations. Then you narrow down your differentials, and then you progress with the case. Then the things become because once you have all the information available, then it becomes a bit challenging how to approach the whole thing. So you must always be very systematic. Like you now mentioned regarding the abnormal cells which you could see, atypical lymphocytes might guide you in a different direction. If this patient at presentation had blast cells, that could also have been a possibility, right? So I think, and then you go to the coagulation parameters, look at the organ dysfunction. So that will now help you narrow down the differential diagnosis. Of course, in this patient, some things came up later. Probably schistocytes came up much later in the peripheral smear, and you probably, because things were not fitting in. So again, you ask the hematologist to look at it. So that is why that becomes important.
Exactly. I mean,
Also,
that is
yeah,
what is important is to talk to the lab. I think, unless you tell them, they do just routine tests, and then though they don't know the history and the background, they don't specifically look for it. That is the problem.
absolutely.
I mean,
Yeah, yeah. And what else was the challenge here?
but
How
only
did
in
you
the first
manage with
slide, it
the?
was totally absent.
Yeah, yeah, exactly. In the first one, it was absent, so that was another thing. How did you handle, and what do you think could be the causes, other causes of pancreatitis? Rupan, you mentioned about the vasculitis and SLE and all of those things could contribute to, but anything else you think could have contributed to the pancreatitis in this patient?
First thing that came to our mind was vasculitis. So, any autoimmune cause of pancreatitis like IgG4 antibody has to be ruled out here. And since there was history of fever was present, so it could be due to any infection and sepsis.
This
And
patient developed pancreatitis after you started certain medications, right?
yes, ma'am.
Rituximab
Rituximab is
induced, yes,
rituximab induced
that is
pancreatitis
not
could be present.
very uncommon. I mean, it happens.
Yes,
No,
ma'am.
no, steroids. He was on pulse methylpred, right?
Yes, both steroids could have caused, and rituximab also has case reports, and
Yeah,
it's not very
that
rare
Tanmay,
to
I
happen.
wanted Rupan to put
Yes,
that
yes,
first before
yes,
IgG4.
of course, yeah.
Before IgG4, you have to mention rituximab and pulse methylprednisolone,
Yes,
right?
ma'am.
So about that, I think that is another thing. Um, yeah, it's all good from my side. Mohit, you want to?
Yeah, so I will just suggest some questions that you have to be prepared for when we are presenting this type of case. So, as Shashwati mentioned right from the beginning, that we have to be able to make DD and don't get biased with the because this will happen in the exams also. When you go for your exam, then again you would be knowing maybe the case has already been diagnosed. Probably the case has been already been diagnosed there also where the patient is lying. So that ICU has already diagnosed the case, but that is not what an examiner wants to hear. The examiner wants to know whether your thought process is correct. How do you approach the case? So that is what the examiner wants to know. The examiner is not of this the presentation. The purpose of presentation today actually was for you to appear as an examinee, for you to get practice as an examinee, isn't it? So this was not a case presentation in an ISCCM meeting where we are going to present an interesting case. This was supposed to be a case where you are appearing as an examinee. So the approach for an examinee has to be different. So you start from basics and then you go on to advanced things. So if you straight away jump to advanced things, that is again not a good approach. The examiner wants to know that your basics are correct, and you will start with the basics, and then you will go on to various advanced things. That said, once you have this type of case, then the questions can be asked on one is the complications, various other complications of SLE, diagnostic criteria, etc. I also already mentioned. So various questions can be asked about the complications of SLE, the diagnostic criteria of various types of vasculitis. Okay, so once you have this ANCA, etc. positive, so the various types of vasculitis that could be there, So what is a large vessel vasculitis? What is a medium vessel vasculitis? What is a small vessel vasculitis? How to what would be the various presentations of each? Now, if you have ANCA positive, then we are obviously talking about small vessel vasculitis. So what can be the types of small vessel vasculitis? Where do you think this might fit in? So that is one part. Etiology of pancreatitis, of course, SASWATI has already discussed. Then it can also go in the direction of the various indications of plasmapheresis, what is the categorization of indications of plasmapheresis, and how the plasmapheresis would be done. It can go in the direction of the antibiotics, where you have used various antibiotics that you have used. So you had enterococcus, so even it can go into the direction of management of enterococcus, the various breakpoints, what is vancomycin creep, and so examiner can take you into various directions wherever it might feel like, wherever the person might feel like. So you have to be prepared in all types of directions. Okay, so do not go with a fixed frame of mind. Do not go with a fixed frame of mind. I know I have a case of SLE with TTP and I'm going to present like this. The examiner can take you in any of different directions. So you have to be prepared on all sides. So that is, I just wanted to give you an example of how things can go into different directions. Otherwise, Tanmay, it was a very interesting case. So lots to learn. Don't get this type of cases commonly. So lots to learn for us. Thank you.
Yes, I think obviously it's very interesting case, an uncommon rare case. But you are right. I think this should be taken as a sort of like a practice for your examination preparation as well. So it's a great help to you all the trainees and you guys when you are getting an opportunity like this to present to a forum of seniors and examiners to actually learn yourself how it can help you in future to prepare for the exam as well. So how to approach a case in a systematic way, step by step. Okay, other than that, obviously this patient was admitted in January, February. So by this time, you know everything, what has happened and all, but don't get biased with this. You should present it as sort of, you would present it.
Yeah, and mention always the common things in the differentials first, and tell the less common later. Because once you say the uncommon things first, then the examiners, they suddenly get very excited. They really want to take you down a different path, and you really don't want to allow them to do that, no? So,
Yes, ma'am.
just practice it in a more systematic way. Your presentation was very good. The case was excellent. But as far as examination is concerned, we need to follow a particular system. Okay. So I'm sure you will do that the next time. But wonderful presentation, and thank you. And thank you for bearing with our questions. Thanks.
Okay, thank you.
Thank you
all.
everyone for being here. It was actually a very interesting session for all of us. And the aspirants also have did put the comment that it's an interesting session. Thank you, Rupan sir. Thank you, Tanmay sir. Thank you, Saswati ma'am.
Thank
And
you.
thank you, Mohit sir, for being with us. We want to see you more in our case-based sessions. Thank you.
Thank you. Thank you. Good night. Thanks.